Hello and welcome. I'm Lori McFerrin with the ALS Association. I know today we have a nice mix of people who joined our webinars previously and a group of newcomers, so welcome all. I'm going to share just a few comments before today's presentation. First, the presentation will be recorded. Both the presentation and the slides will be available on our website, als.org, within just a couple of days. Second, questions are always encouraged. The presentation and the slides will be available on our, questions are always encouraged. Feel free to enter your questions in the Q&A section anytime, and Dr. Mehta will address them following her presentation. And lastly, please stick around after the presentation for a quick 3-question survey. Your responses help us understand how you're being notified of our events, how well we're addressing the topics we're presenting, and what programs and presenters you'd like to see in the future. Now, I'd like to get us started with the real reason we're here. Today's presenter is Dr. Ambreen Mehta. Dr. Mehta is an associate professor in the schools of medicine and neurology at Johns Hopkins School of Medicine. She is a part of the palliative care faculty at Johns Hopkins and is the palliative care expert in the Johns Hopkins Center for Specialty ALS Care. I'm going to refer you to our website to read more on Dr. Mehta's experiences and accomplishments. Today, you can observe for yourself her commitment to helping people with ALS live as well as they can in the way that they choose. Dr. Mehta, take a minute to pull up your slides, and when you're ready, the floor is yours.
Thank you so much, and thank you so much for having me. Well, I'm really grateful to talk about this subject with everyone today, living fully, living well, what palliative care is and the approaches for people living with ALS. This is a very difficult disease and one that brings along with it a lot of difficulties, but also with the intention of thinking through ways to help people who are living with this disease live well and live fully. I will share that I do receive speaking honoraria for the Muscular Dystrophy Association. And today we're going to think through together the questions about what is palliative care and how does it help people living with ALS? What is hospice and how does it help people living with ALS? And what does palliative care do to improve the care for care partners as well? Let me begin with a story of a patient of ours who I had the honor and privilege of journeying with. This is a 59-year-old gentleman who loved to run, as I do, and we had that in common. One day he had a near fall while running, and then he developed low back pain that persisted. Because he was a long distance runner, he didn't think much of it, but he began to have progressive gait instability, difficulty with his walking. And he was even able to complete a marathon 2 months later after this began. But because of this instability, he had to stop running. He went for a spine evaluation 6 months later and was treated with an inflammation injection for his low back. But by December, he continued to grow weaker, and that weakness spread to his core of his body as well. He was referred to see neurology a year after his first fall, and he was diagnosed with ALS at that time. He slowly lost weight, developed significant anxiety, had insomnia, and worsening breathing. I'm sure for many of you listening today, you yourselves have experienced or your loved one has experienced some or parts or unfortunately all of those things. Or you're worried or scared that you might see or experience some of those things. And the unique palliative care needs for people living with neurological illnesses like ALS are common and also different from other diseases. People with these diseases experience a lot of symptoms. They develop difficulty with communicating. Sometimes they develop difficulty with understanding or developing an ability to fully have what we call medical capacity. There's a long, prolonged decline that happens slowly over time with a lot of ups and downs. And because of that, because it's over a long period, people have a lot of needs from their care partners. There's also a lot of uncertainty about what's going to happen because there are ups and downs, plateaus, where people stay the same for a long time, but you're not sure how long that is. And then the ability to make complicated decisions and the need for making complicated decisions throughout the disease challenges people to think a lot about some of the difficult topics in medicine. So where does palliative care come in with all of this? And that's what we'll spend the next few minutes talking about, because that's a lot of suffering I just described. The woman who founded the first modern hospice, actually, her name was Cicely Saunders. She was from the UK, and so she was eventually given a Dame title for her incredible work. She said, "You matter because you are you, and you matter to the end of your life, and we will do all we can not only to help you die peacefully, but also to live until you die." And I say this quote because it really is the foundation of the practice of palliative care, which focuses on total pain, which is what she described. And you can see this concept of total pain is not just physical pain, it's pain that includes the mind, body, and spirit. And what's also not included here is financial, and care partners are included here as well. And so palliative care as a practice is focused on taking care of the whole being. The difficulty with understanding this and the need for caring for all these components means that palliative care is pretty complex, and sometimes it's hard to explain. When I talk with you today, there's a distinction that's valuable to be made. One is that there is palliative care as a concept, as an existence, as a framework, and as a field, and that's what this is. And then there's palliative care as a subspecialty, as a medical subspecialty. So when I say I'm a palliative care specialist, that means that it's my subspecialty, just like any other specialty doctor or specialty practitioner, right? There are nurse practitioners and physician assistants and nurses and social workers who are all trained in the specific care of palliative care. And they're specialists who do that all day, every day. But you have medical teams who provide you with relief of suffering in many of these areas, who may not have done extra training or may not have done a focus in palliative care as a field, but they are still providing a relief in suffering. And so that's everyone taking care of pretty much anyone. So many times people talk about palliative care, and it can be confusing because there isn't always a specialist available, but they're still receiving some form of palliative care. Through the talk, when I refer to palliative care specialists, I'm referring to palliative care folks who have done extra training to do that. So what's the benefits of palliative care, whether it's a specialty or a field? Well, we talked about a little bit of that. You can help people relieve their suffering. Palliative care as a specialty has been shown that it can help people to live better, can help people sometimes even live longer. It's dedicated time and space to addressing the symptoms and suffering of people who are living with severe illnesses that are impacting all of their being. And there's a way of, they provide a way of matching treatment options to goals. They work together with your other doctors, and they don't take away from the care that you're currently receiving. They don't want that to stop. And we'll talk about that a little bit more. Sometimes palliative care is provided as a team with many different people, because as we just described, there's different forms of suffering. And sometimes it's just someone like me who's in the clinic working with the existing resources that you have. So throughout the talk today, we'll do a few myths or truths and to get you thinking. If when I put them up, I'd love you for you to think to yourself what you think the answer might be, and we'll talk through them as we go along. So patients must stop seeing their ALS team if they're seeing palliative care. Truth, myth, or you're just unsure. Let's talk a little bit more about that. So palliative care specialists, now these are the specialty team folks, they are trained to be comfortable with uncertainty. And in medicine, I can tell you as a doctor that in medical school, we're trained to come up with answers to try to fix things. And we're looking for ways to help. And I'm sure many of you listening know already that most of medicine and most of life is pretty uncertain. And there's a lot of diseases that don't have answers. ALS, I know that a lot of people are working on finding a cure, and we need that. And we also know in the meantime that we're trying to get through the next day. And so there's a lot of uncertainty that comes with this disease, and a lot of flexibility required as well. So palliative care specialists can help you be with that uncertainty, recognize that, and figure out ways to plan within that uncertainty. We're trained to have a different approach to manage complicated symptoms being things like pain and sleep and nausea and poor appetite and itching, anything that might come up. We have the skills and tools that are just slightly different than the tools that maybe your ALS team use. And those are not wrong. Those are certainly the important first steps. Sometimes those don't work. And so palliative care experts can help to think a little bit outside the box when it's necessary. And so those are tools and skills that we can bring. We work as a multidisciplinary team. Whether or not that is always available, it's how we are trained. We're trained in our programs to have a social worker, a chaplain, a case manager, to have nurses and advanced practice practitioners, pharmacists, and not most teams don't have every single one. But because we're trained like that and it's required, kind of understand what it means to work as a team. And that's really important for ALS because the standard of care generally is to have a multidisciplinary team approach. So palliative care can easily fit in with that and work alongside the doctors, the nurses, the care team you already have. Sometimes we just create additional time for support. In medicine, I like to tell a lot of my patients in the clinic that many times the focus is, as we need to have, every team has to figure out what's going on with the disease. How is it progressing? What kinds of medicines are we going to do right now? And that's important, extremely important. And so many times, because it's so important, much of the time is spent on taking care of that. So there's not always a created time to focus just on support for the person living with this disease and their families and care partners. And so sometimes I say, not every feeling needs a medicine. Not every feeling is a problem. Most feelings are normal, and we should be able to create a space in which we can think about and process those feelings. and just think through them. Doesn't even need necessarily a therapist, doesn't need many more sessions sometimes, just needs to have a space to talk about, this is terrible, this sucks, I hate living with this. It's changed everything about my life and my family's life, and I don't like it. It doesn't have to be anything more than that. We provide sometimes a form of continuity of care in specific settings. So if I see a person in the clinic, then they go into the hospital, whether it's myself or I can relate to the palliative team in the hospital, what's going on in terms of somebody's goals, their wishes, how they would like to continue their care. I can communicate that. Sometimes because certain teams, and especially in the hospital, certain teams have to be on call, medical teams have to be on call 24 hours a day, 7 days a week. And because of that, no doctor, no medical team, no nurse can be there 24 hours, 7 days a week. So they rotate, but our team, for example, can be there Monday through Friday, every day, to make sure that we're passing on the same messages to the new team that comes along. And then we can help think through, what are the transitions to end of life care? When are those appropriate? When should we even think about that? And many times the answers are, you can start thinking about it as soon as you feel ready to. It's scary and it's hard, but at least there's a place to process through that. And no actions have to be taken, but at least we can start thinking through what would be the things to look out for to know when our transition's needed. So what are the goals of palliative care for people who have ALS? We focus on alleviating symptoms and improving comfort, enhancing emotional and psychological well-being, facilitating communication and decision-making, and supporting patients and their families through the journey. Not much different from what we do for people with other diseases, except the context and quality, the context and issues that come up and things that need to be discussed, that slightly varies for people living with ALS. So here's our next myth or truth. Another one about people having to give up seeing their ALS team if they start seeing a palliative care physician or a palliative care specialist is, nope, you don't have to give up your healthcare team. You're not switching into palliative care or changing anything different about the care you're receiving. All right, so the next one is, patients cannot continue ALS treatments with palliative care. So that also goes alongside with the question of, when should you ask for or think about having a palliative care specialist added to your team? In the past, if you see the first graph there, the old way was you get diagnosed with a disease and then you would go along and you get treatments that are aimed at either trying to cure or prolong your life. And then when those are not really working so well, or those are causing problems, and you no longer can or want to or going to be able to take them any longer, then people start thinking about palliative care. And then because the treatment options are having problems, and we're starting to run out of those disease-directed treatments, palliative care comes towards the end of life, and then soon after comes hospice care. And that's why a lot of times palliative care is thought to be the same as hospice care. But hopefully by the end of this talk, you'll know that they're not. But the new model is really that the minute you're diagnosed with a disease that's pretty intense, like ALS, what I know ALS doesn't have a cure, but there's other diseases that do have cures, and they still, on diagnosis, recommend considering getting a palliative care specialist involved, because palliative care, as I shared, can help you relieve your suffering as you're getting disease-directed treatments. And sometimes that helps people actually get treatments longer. Sometimes I've had patients who have a lot of emotional distress, or they are having a lot of symptoms, physical symptoms, and they don't know if they want to continue, or they don't think they can or want to continue. And we can help with that, relieve some of that suffering, and allow people to continue with the treatments that they actually do want, that are goal aligned. Now, sometimes people along the way say, well, I thought I wanted it, but I no longer do. And that's okay too. And that's when we think about hospice care, if it's appropriate. So palliative care, as you can see, really goes alongside a long time. Then when it's time for hospice care, we talk about hospice care. Sometimes they overlap in ALS specifically. That's where I don't have a diagram for this one, but sometimes the blurry line between palliative care and hospice care for people who have ALS can be that we're trying to get more equipment and see the doctors and for a little bit longer, or see the specialist for a little bit longer, and maybe hospice could work, but we're going to hold off a little bit longer on that. And sometimes people who are in hospice care still are coming back to see their ALS healthcare team. So that kind of also blurs the line a little bit. But this is the general idea. And then hospice care has bereavement care too. So extending the amount of care people and their families receive beyond the time that the short time that used to be provided. So let's go back to thinking about my patient, Mr. R. He continued to struggle with breathing and anxiety, and he started BiPAP, which is that breathing support. In case you're not familiar with it yet, it's a face mask that helps push air in for people whose lungs are becoming too weak to breathe for themselves. This helped with his energy and it helped with his breathing. And we started a few medications, including antidepressants and some anxiety medicines. And they started to help him a little bit. About 1.5 years after that first fall, he was losing weight and his ALS team recommended a feeding tube. So he went ahead with that and had that done because he felt like it was consistent with what he would want. And so I saw him around this time for uncontrolled anxiety, and he was having panic attacks constantly. And that was really frightening to him and to his family. And it actually made them start worrying about what was going to come next with his disease. So we started to talk a little bit more about what to expect, the uncertainty, the fear around that. And so that's where this concept of complex decisions with ALS come into place. People who have ALS are challenged with the difficulty in feeding. They're then challenged with difficulty with breathing. Their speech and communication can decline. And we also do actually talk about something about resuscitation that's called CPR. And I'll talk about that in a little bit. But these are some big, complicated decisions. And some of them help people live longer. Some of them help people live better. But they don't help everybody in the same ways because everybody's different, and people's own personal values, beliefs, religious ethics, they all come into play when thinking through these decisions. So a one size doesn't fit all. And that's what palliative care can help think through, can help people think about, how do I connect what's important to me, who I am, what do I want to live for, what do I want to look forward to, and where am I okay saying, I'm good at this point, if ever. And so these are some of the hard topics that do come up, and that we can help think through as they progress. The other important part is going back to that concept of uncertainty and ups and downs. The decisions that people make about these things can vary based on what you're experiencing throughout your disease. Some people early on will tell me, I don't want any of these things. And as they go through treatments and as they go through more, they rethink some of that. Some people don't. Some people start out saying, I want all of these things. And as they go through, select, pick and choose. Allowing for that flexibility is incredibly important. It can be exhausting and scary, but it's incredibly important. And allowing for the conversations to have the reassessments and the rethinking puts that power, hopefully, and that control back with the person living with the disease and experiencing this, as well as the care partners, to understand the processing through these decisions that people come up with. And there's never a right or a wrong answer. It's the decision that you make at the time with the best information that you have possible. And conversing about that with your healthcare team can also ensure that your healthcare team can support you the best that they can. So when you've thought through some of these decisions, it's also important to think about, as you share them with your healthcare team, the other people who are part of your life, who are going to be the ones helping to speak on your behalf if you cannot speak for yourself. Sometimes that happens to people where they can't speak for themselves. Sometimes that's not true. And it's important to know that your medical team will always defer to you. And if you cannot, then your family and your loved one, and the one who, it doesn't have to be a family member, it can be the person who knows you the best, not related to you at all. That's called a healthcare power of attorney or a healthcare agent. The best thing that you can do as a person who has been diagnosed with this disease is to share with them what you would want. Because again, they're answering the question, what would this person say if they were able to? And this that I'm referring to is solely talking about the medical component of things, not financial, because you can have a separate financial power of attorney. It is important that if it's especially somebody who is not in different states, the order in who is the default. So if you could not speak for yourself, every state has a default person that's usually a family member. For example, in Maryland, the next person is your spouse. If you're legally married, even if you haven't been living with that spouse, it would still default to that person. So it goes to spouse, then it goes to adult children, then it goes to parents, and then siblings. So it's important to know who would be the default, and it's okay if you don't want them to be. Maybe they cannot, or maybe after a certain period of time, you need to switch because somebody cannot do it any longer for many reasons. So if you don't want the default person to be that person, then writing it down and designating that individual as your healthcare agent is extremely important. Honestly, it's even more important than having conversations. And I think that is not to take away from the conversations that are necessary, because but if that person knows you well and you've at some point expressed to them what's important to you, your value system, not every medical decision can be predicted. Not every medical decision is known ahead of time, not even by the healthcare team. So you may not have told them, I want X, Y, or Z done or not done. And so if sometimes there's a lot of gray areas, and we make decisions and help people understand how best to move forward within a framework of who that person is and what a good quality of life means to them. And the focus is really on quality of life. So I think that one of the first questions I ask the people is, just tell me who speaks on your behalf if you couldn't, because that person is going to be the go-to person when we have complicated decisions to make. So if you do have these conversations, when you do, I encourage you to write them down. Where do you write these down? You write them in advance directives, also known as living wills. These are legal documents to tell people what you want for your medical care. You do not need an attorney to complete these. Many times people go and see an attorney, they'll do both their financial and their medical, but these are meant to be living, breathing documents that reflect what you want, as I said earlier. And so in order to allow for that flexibility, you shouldn't have to go and see an attorney and pay any money to complete these. In many states, and I would encourage you to just do a quick search, they have them for free through your state. And in Maryland, for example, you can make them legal by having 2 witnesses or notarized. So they're meant to be updated regularly. And I usually describe them as the same as formal evening wear. You take them out once a year, you make sure they still fit, or any major event. And that will help your medical team also think through with you what you want and think about how not to do harm to you. The picture I have here is of one called the 5 Wishes, and it's pretty nice in that it's a different style. The one that comes from the state in Maryland, pretty straightforward, meant to be easy to fill out, but not a lot of room to write in your own wishes. This one has a little bit more, if you like to do that, if you like to explain in detail what you want or what you don't want or what you're thinking, it has room to do that. So there's different forms out there. Now, this is different from the physician, what's called a POLST form, the physician order life-sustaining treatment form. The POLST form in Maryland is called the MOLST form. Different states have different names. It's also now just called the portable medical order form. It is actually a doctor's order. So you do not sign this as a person with the disease or a family member. You don't sign this. It is the physician who signs it because it's a doctor's order, or a nurse practitioner or a physician assistant in places that says, it will translate your wishes to medical things, dialysis, transfusions, going to the hospital, having CPR, those sorts of things. So we've talked about a couple of ways to make sure that your wishes are known, and that brings up a lot of times concerns about end of life and hospice. And so we'll spend the next few slides talking about end of life care and how it's related to palliative care and how it's related to hospice care. So palliative care, as we talked about, is a field of relieving suffering and improving quality of life. In my own clinic, I actually describe myself as the quality of life doctor because that's what I'm really focused on. And I want to know about that. And I want to enhance that for people because we're still talking about living. And living includes talking about dying. And so at some point, people need to talk about end of life and those wishes. And that leads into conversations about hospice. And so hospice is one part of palliative care. And so all people who have hospice care are receiving palliative care, but not all people who are receiving palliative care are receiving hospice care. So hospice care is specialty care that's person-centered, that stresses the coordination of care, stresses the clarification of goals of care and communication. Sounds like palliative care, right? It's an interdisciplinary team of professionals trained to address physical, psychosocial, spiritual needs of the person, also palliative care. And the team supports family members and other intimate, unpaid caregivers. Again, palliative care. It's medical care for people with an anticipated life expectancy of 6 months or less, when cure isn't an option and the focus shifts to symptom management and quality of life. That last part is clearly how hospice is different from palliative care. And this quote comes from the Hospice Foundation. That's a national foundation. So they're quite focused on this care. So as you can see, it's quite overlapping, but there are some differences. So what are these differences? When we're talking about hospice care, as you can see, it focuses on and treats the person, not the disease. And we think about hospice as you can see in this picture here, multidisciplinary. Many of these aspects are similar to palliative care teams, but some of them are not. Some of them do. Some palliative care teams, one's in the clinic, one's in the hospital, may not have things like home health aides or bereavement counselors. Those are specific to hospice as a service. So when is it time for hospice? In the previous slide, I mentioned this number of 6 months, and that's actually a Medicare criteria because hospice is a Medicare benefit that pays for hospice care in the United States. In other countries, they do not have that because they don't have Medicare. And so in other countries, outside the US, palliative care is this, there is no such term really as hospice care. It's just palliative care through the end of life. And then when they make this switch, they go to palliative care homes or services that are separate. But in this country, we have Medicare that pays for hospice as a benefit. And so they stipulate that this person, based on their expected trajectory, based on what we've been seeing with them, would expect to have a natural end of life within 6 months if the disease continued at the rate that it is currently continuing at. So that is an important component of considering hospice, because it is important for us to think about when we're thinking about when is it time for hospice. There's a lot of things that we consider to understand, is somebody changing in a way that we would consider a natural progression to be 6 months or less. You can see a long list here, and a lot of that has to do with really change. So again, thinking about uncertainty and how we're looking at prognosis is we're looking at the change and the rate of change. Changes in breathing, changes in weight loss, changes in cognition, changes in their function, changes in their eating. Some people decide that they do not want to pursue a tracheostomy or ventilation, which is a breathing tube in the neck, where you're connected to a ventilator, a permanent ventilator, and that is called invasive ventilation. And some people don't want even what we call non-invasive ventilation, which are this machines called CPAP and BiPAP, which are the face masks or the nose masks that help people breathe. Some people don't want that either. Some people don't want a feeding tube or don't want artificial feeding. So those are important things that when we get to that point where they need those things and they want to focus on how to live the best life they can without those things, then we consider hospice as one support option for that. Sometimes people are ready to say, my priority is comfort over all else, no matter how long I have to live. And so that is when hospice is the best support team, most robust support team to keep somebody out of the hospital, to keep their symptoms very, very controlled. So when we think about another truth or myth, we think about patients, people ask, can I continue my ALS medications while we're in hospice? So I just told you all the wonderful benefits about hospice, but let me tell you about some things that may not be covered while you're receiving care in hospice. And these are important because they may help to decide, is hospice the right service for you now or service for me later? So some of the medications will not be considered, would not be covered under Medicare. Those would be life-prolonging medications, and those for ALS are things like Radicava, Riluzole, Relyvrio. They would not be covered by, the cost would not be covered by the ALS, by the hospice team. Now, some people have a second insurance that will pay for them, and hospice would not stop you from having those insurance agencies fill those medications and continue. But if you have to go, for example, for lab work or follow-up or tests, hospice wouldn't cover those. If you already have a feeding tube at the time of hospice admission, the nutrition can continue, but once the body is no longer able to tolerate these feedings, generally hospice will discontinue them because they want to prevent uncomfortable side effects from the extra food and fluid, because that actually does cause discomfort. And then hospice will not cover rehabilitation services. So if somebody's getting a lot of benefit or value from going to physical therapy or occupational therapy, we recommend finishing those things up first and then enrolling in hospice. If there's any surgeries, for example, you want a feeding tube and you don't have one yet, and you're going to need one, then we wait. expensive equipment. So in ALS, for example, the power wheelchair, the eye gaze machines, any of those expensive equipment that companies like the ALS Association can help give, they generally, let's say you need to get that started, generally it's hospice won't cover that. So we wait to get all those things. They won't make you stop them. They won't make you take them away, but you just want to wait until you get all those things. Clinical trials are not covered in hospice. And then if you're already getting non-invasive ventilation, that's the CPAP or BiPAP machines or Trilogy devices, or you have a ventilator, I didn't include that, excuse me, but you have a ventilator machine. I think it's very important to have your ALS healthcare team, before you sign with a certain hospice, speak to them about the management of these machines with that ALS, with that hospice team. Because ALS is a rare disease, not every hospice agency is familiar with how to manage these or how to adjust them. And so, or sometimes with other diseases, sometimes chronic diseases like COPD or other illnesses that have these sorts of machines, they do not meaningfully improve quality of life for people. And so generally with other diseases, hospice is taught that we help transition people. They'll help transition people off of those because they're no longer serving a meaningful way of having a good quality of life. They're only solely prolonging life. In ALS, they do both. It does both. And so they just may not have the understanding or experience or ability to support that. And so if that's the case, you may not be able to go with that hospice agency. You may need to find another one. Some hospice agencies may not be able to do it themselves. They'll contract with a respiratory company to manage the machines. But you just want to make sure that then if they're contracting with an extended company, you won't get a surprise bill or something like that. So it's not onto you to have to do the legwork of this, but I share this with you so to empower you to speak up and encourage your healthcare team to say, look, I'm interested in this, but somebody once told me that it might not be so easy. Can you just make sure that you've spoken to them? And the team should know and would know how to do that. They've had lots of experience, but just for you to be aware that some of those things need to happen behind the scenes before we sign up with hospice. All right, so on to our next myth or truth. Patients must change their code status to do not resuscitate to enroll in hospice. This is one where I don't have a separate slide for this, so I'm going to tell you that that is a myth. And you do not, and so that is because people sometimes worry that if I want to go home with hospice, then they're going to make me change what's called my code status, and that's referring to do not resuscitate. You can do that. The thing to know is that if you do go home with hospice and you do have what's called a full code, where you want to have CPR done, you want to be resuscitated, you would be put on a ventilator. They would, if you're home with the hospice team and this happens and you need this, you will have to call 911, disenroll from a hospice and go to the hospital. It's not a problem. It's just something that you should know would be the reason why people talk about code status when they're talking about going into hospice. Now, if you're going to a facility with hospice, sometimes the facility, not the hospice, but the facility will say you need to change your code status because now you're with their facility and they're responsible for you and they don't want to have to send you to the ER. They want to keep you with them, which is it's in a good way. It's meant in a good way. But if you're not okay with that, if that's not acceptable, that's okay. That either means you maybe find another facility, maybe find a way to go home, or maybe we're not ready for hospice yet, and that's okay too. All right, all patients are moved into a hospice when they enroll. Is that a truth or a myth, or maybe you're not sure? So where do you go for hospice? You go wherever you call home. No one will force you to move into a hospice. There are options. Not everyone can go home. there's a lot of care for people who have serious illnesses, and care changes in different phases of life. So sometimes people will have been living at home with the care partners they have for a long time, but in this next stage of life, it may just be too much. Sometimes it's also an opportunity for loved ones to shift from being a care partner to just being able to focus on being family and letting another team take care of somebody, take care of them for in that capacity. It is important to note that hospice does not cover any full-time caregiving. So that is a big gap in our care. And I hope that if you're listening and you feel compelled to want to change this, to write to your local representative to ask them to work on the laws for this, because there is no coverage and it's a huge burden. It's a huge responsibility, excuse me, not a burden, but it's a huge responsibility and a huge commitment from families that often is not available. But we put a lot of that on care partners, and it's exhausting and stressful, and we're well understaffed and well undertrained for that. There's an option to move into nursing facilities with hospice agencies coming there. There's also something called an inpatient hospice facility. Those are generally for people who have uncontrolled symptoms, needing more significant care because their symptoms are severe. And the hospice agencies will determine who does that and how they do it. So let's just quickly compare what to expect with hospice. Symptom management. They'll give medications, medical supplies, and equipment. They do care partner support with more touch points because there's a team coming to the house. And you have a 24-hour on-call, 24 hour, 7 day a week team to prevent ER visits and hospitalizations. And then there's support for grief and bereavement. And you will not get 24-hour care at the bedside. Medications aimed at ALS are going to be stopped, generally through hospice. Nutrition could continue for the feeding tube that's already in place until it's causing problems. We talked about the breathing machines, and we talked about some of these rehabilitation surgeries, ALS machines, those things will not be started. And we talked about experimental treatments or clinical trials or medical treatments solely aimed at prolonging life will not be covered. Let's finish up together with talking about care partner support, which we all know is significantly important. From the ALS Association website, 68% of ALS care partners said that they spent more than 30 hours per week providing care to their loved one. Almost 1/2 of care partners said they felt unprepared for challenges in caregiving responsibility as the ALS progresses. The cost for medical treatment and services topped the list of stressors for people with ALS and their care partners. 1 out of 4 people with ALS and care partners said that they had to borrow money or go into debt because of their ALS treatment or to provide caregiving, respectively. And 44% of ALS care partners cited depression as a top concern. So supporting our care partners means it's better care for the patient, and it improves the patient's quality of life, and of course, helps the entire community. So the needs for care partners evolve over time. We know in the initial diagnosis, you are just thinking about having the correct diagnosis. You're thinking about the diagnosis and symptom onset mismatch, right? I'm having all these symptoms, but nobody's telling me what's going on. It's hard to understand the disease, wrap your mind around all this. There's trying to understand what's going to happen to me now, and just kind of collecting all of the support resources that are around and just trying to maintain some semblance of the existing quality of life. Those are all challenges. Then as the disease progresses, there's going to be changes in the social roles, changes in the financial roles, and maintaining quality of life, setting some boundaries. And then towards the end of life, as we talked about, really trying to think about what is normal, what's not normal. Do we stay at home? Do we not stay at home? How do we ensure comfort? How do we ensure that we're taking care of people and their grief in anticipation of what's coming? These are all the cares that are changing over time. So we stay organized by supporting care partners. Ways to do that are staying organized. Ways to do that are to help maintain connections, helping in maintaining daily routines, helping palliative care and teams can help think about self-care. We can help think about addressing barriers to that self-care. We can help think about utilizing resources that exist and maybe finding resources that don't exist, giving you some confidence in in managing that disease. You're doing a great job. Maybe you don't know because it's just so many things to balance. You don't know how great of a job you're doing. And then thinking about some of that advanced care planning, as I talked about earlier, can be really important to help ease the mind of what am I going to do, and who's that person, and what does my person want, through going as we all go through this. It is important to have a backup plan. As a care partner, it is very important to think about, if something were to happen to you today, who will take care of your loved one tonight? I don't think I'd ever learned this until a geriatrician taught me this. And I think it's also important to think about, what are some of the other logistics that are needed to provide care for your loved one if you can no longer provide that care alone, having a plan in place and sharing that with your healthcare team. So some of these things can be discussed with your healthcare team in terms of coming up with that. And some of these things can be done with some of the resources that I'm providing here. Educational resources that are online, all of these are free. Obviously, the ALS Association has a ton of resources, including allowing me to speak to you about these today. That there's these companies that have really beautiful, thoughtful resources. There's resources specifically for care partners through the websites of ALS Association, through the Les Turner Foundation, and through the ALS. Each one of them have learning series, so really much more in depth than even what I'm able to provide. I turn people over to those. So in closing, and thinking about my patient and what happened to him, he expressed that his wishes were to not be resuscitated. We talked about invasive ventilation, and he just wanted to prioritize for himself comfort over everything else. And his partner knew his wishes. And when he was close to the end of life, they decided to choose hospice and focus on comfort meds only. And he actually died peacefully with his wife as his side. And we were able to be there with her at the time of his death. So I'm going to stop there. I know that we're close to the end of time, and I want to make sure we talk about some questions, but I'm so grateful. And I know this was not comprehensive and not meant to be, but hopefully we can do some more talking as well right now.
Dr. Thank you. I know so many of us were looking forward to this, and you're right, it's the beginning of a conversation. I'm not seeing any questions right now, but I want to cue people to definitely put some questions in the queue. I want your questions to be answered. But in the meantime, I spoke with Dr. Mehta this morning and just shared with her some thoughts and questions that come up regularly. So I'll address one of mine, and then I do see that someone has listed something there. So as I shared with you this morning, there are so many people with ALS who have multiple providers and can be overwhelmed with the thought of seeing yet another one. Can you help us understand what a palliative provider might do that isn't already being done by the care team?
Yeah, that's a great question, and one that I get a lot of. It is. I told you about disadvantages of hospice. There are disadvantages of seeing a palliative care specialist. It's true. So we're a specialist, and for physicians or advanced practitioners, so like NPs or PAs, there's a copay. So that's another financial, for some people, it's not burdensome. It's just like seeing a cardiologist or a pulmonologist or any other medical specialist. It's nothing extra than that. But it is another doctor or another provider. And so there's time and sometimes money. And, hopefully today, a little bit of those gaps that I shared kind of help to clarify that our expertise in complicated symptom management and our expertise in communication can help our are different from the healthcare team, because the healthcare team often is focusing on the disease management itself that a palliative care specialist won't do. I will not complete, I will not be thinking about, well, I will be thinking about it, but I will not be prescribing, for example, ALS medications. But if there's complications from those that are making it difficult to go to take them, and you want to take them, then we're thinking about two parts of that. One is the symptom part of it, and how can we help you to, and do you really want to continue it? For example, I've had patients say the side effects, no matter how much we treat them, it doesn't make it worth the prolongation of life that they might offer me. So I would rather just take my chances without them. So I think the support for patients and families, the ability to communicate about and talk about some of these complicated, hard, scary questions that might come up. And I tell my patients when I first meet them that, look, I am here to be what you need. Sometimes you might see me once a year. You might see me once every 6 months. You might need me at a certain time once a month until things settle down. It's really, it doesn't have to be a regular visit, but I do like to check in every 6 months to a year if they'll have me. Because sometimes you just don't know what you don't know. So,
there was a question in the queue. There's a couple of them actually, so we'll try
okay,
and get to those in the next couple of minutes. But you were
sure.
talking about you're not going to prescribe the ALS medications because the ALS team will do that. But so the question is, if you have a family member who is maybe having some side effects from those medications, that might be when palliative care can become involved in. And if you don't have a palliative care provider at this time, what would you suggest that folks do to address side effects from medications?
My first answer is, my first recommendation is always, and even for my own patients, my first question is always, have you spoken to your ALS team? The reason is because we want to make sure if it's a new symptom, let's make sure everybody on the team, all about communication. So let's make sure everybody on your team is aware of what's going on. We also need to make sure that this is not, that we don't want to assume that it's a medication side effect. Let's make sure that it is just that. Because if that's the case, then we don't want to miss something new going on. So I always recommend, even when I'm involved, I say, let's tell the nurse practitioner or the neuromuscular specialist, your healthcare team. And then many times, if I having a palliative care specialist is very important, but I recognize and know, having talked to many colleagues and also many patients and care partners, that we're not available everywhere, and that's a big problem. And we're working on expanding that. There's two ways we've encouraged people to try to get more palliative care. One is bringing it up to your care team and saying, "Can I get a palliative care specialist?" They may say, "We don't have one here," but I would first ask, because sometimes the care team doesn't refer because they're not sure or they don't know themselves. Two, see if it's possible, especially within your state, there may be a palliative specialist who can see you remotely in your own state. So that increases a chance of accessing them. And if that's not available, then a lot of the free websites that I've offered have palliative care information on them, and I have a lot of actually experts, including there was one on INPCS. They have experts who can help you, not with specific medical questions, but can kind of help in general and provide some general guidance and information. The next best thing also is, a lot of social workers in this world are really extremely knowledgeable and can be really good resources as well.
Yeah, and really that's what all of the questions were, is how do I get a palliative care specialist? Should
Yeah.
I ask at clinic? Absolutely.
Yes.
It sounds like maybe you even want to go to your clinic or go to your practitioners and let them know why you want palliative care, that you want
Yeah.
that comfort related practitioner who's going to see you through the process.
Yes. I really like
Uh,
saying, I'm really trying to focus on my quality of life. And that phrase, comfort, can sometimes be frightening, because comfort focused care can some places imply I just want comfort only, and can confuse people about, oh, does this person not want more treatment? But I would sometimes say, just, I really am focusing on my quality of life and living well, and I want to see palliative care specialists.
Yeah, well said. I loved your slide that explained how palliative care used to come at the end of a serious illness, and now it really can come right side by side with a serious illness diagnosis and help along the way. I
Yes.
know that we are out of time for today, but I want to thank you. I think I speak for all of us that your perspective and your genuine interest in uh, helping people live their best definitely came through. So thank you for that. Thank you for all the support that you've given us. For folks who haven't seen some of our palliative related tools on our website, Dr. Mehta helped us with 10 things you should know about palliative care. So definitely take a look at that. And for any additional information on palliative care or other topics related to living with ALS, please connect directly with your ALS Association Care Services teams. They will help you find the resources that are available in your area. And I'm going to put in one last plug for please stick around and complete our really brief survey. We want your information. It'll make a difference in future presentations. Dr. Mehta, again, thank you. Wishing everyone a great afternoon.